Hello everyone. Okay, hello everyone. I'm Dr. Priyankita Nath and I'm your faculty for your anatomy for your online session of FMG recall, and today we are going to recall the recent exam, okay, the anatomy questions of the recent exam. I hope you have performed well, and those who have not performed well, so better luck next time so that you do a preparation better in the December FMG, right? So don't lose hope, those who have not prepared well, and those who have done well, I wish them very good luck. So let us start with the recall today. Okay, so a question came on a motorcyclist. This is a clinical type question, okay, as recalled by the students. These are most of the questions recalled by the students, so it might not be exactly the same, but similar to the questions which has been asked in the exam. Okay, so there was a question where a motorcyclist met with an RTA and had a metacarpal fracture. Okay, the important thing here to observe is the hypertrophy, the hypothenar atrophy. Okay, the hypothenar atrophy was observed. So identify the nerve involved. Okay, so they have given ulnar nerve, radial nerve, musculocutaneous nerve, and median nerve. So anybody in the chat who has attempted this question and what they have marked the answer? Anyone in the chat who have marked the answer in this question? Anybody can remember this? So before this, let us study the about the hypothenar and thenar nerve supply. Okay, so you know that, okay, in this image you can see this area is the thenar area, okay, and this is the hypothenar. Okay, so you know that on the palmar aspect, okay, the medial 1.5 fingers, 1.5 till 1.5 fingers up to the nail bed, okay, up to the nail bed on the dorsum is supplied by the ulnar nerve. Okay, on the lateral aspect, the 3.5 fingers are supplied by the median nerve. Okay, this is on the palmar aspect. On the dorsum, the 3.5 except the nail bed is supplied by the radial nerve. Okay, this is by the radial nerve, this is by the ulnar nerve, and till the nail bed it is median nerve. All right. So this is the cutaneous supply. Okay, and if you can see here, okay, the thenar muscles are supplied by the median nerve and the hypothenar muscles are supplied by the ulnar nerve. Okay, the thenar muscles are supplied by the median nerve and the hypothenar muscles are supplied by the ulnar nerve. Any question on this? Anybody has attempted this question in the chat? They can ask. Okay. You can ask in the chat if you have attempted the correct answer, or even if you have attempted the wrong answer. Whatever you have attempted, you can answer in the chat. Okay, so you have seen that the hypothenar part is supplied by the ulnar nerve and the thenar muscles are supplied by the median nerve. So it can be observed by seeing the cutaneous nerve supply. So they have mentioned that there is hypothenar atrophy. So the answer will be your ulnar nerve. Okay, the answer will be your ulnar nerve. So anybody has attempted this answer correct in the live, you can, in the chat you can answer it. Okay. Okay. So after that, let us see, because I have not taught you the upper limb in my online session, but from the next session we'll go through all the limbs, and then I will do a quick recap of the upper limb as well. So what are the important topics to be covered in the upper limb? We'll do a quick recap on that. But this cutaneous supply of the palm is very important, because if they have given hypothenar atrophy this time, they might give a thenar muscle atrophy on the next December session as well. Okay, so they might alter the question a little bit. So if they give a thenar part, then the answer will be a median. If they will give the hypothenar part, the answer will be your ulnar. Okay, so anybody has attempted this question can reply in the chat. Okay. Okay, now they have given another question, that which nerve is commonly injured in indirect inguinal hernia. So they have mentioned about the femoral, the genitofemoral obturator, and ilioinguinal. Anybody who has attempted this question, anyone who has attempted this question can answer in the chat. I will rectify you. So indirect inguinal hernia, which nerve will be commonly injured? Anyone who wants to answer in the chat this question? So before that, let us study about the direct and indirect inguinal hernia. So you know that direct, as the name suggests, direct means it directly comes to the posterior abdominal wall. That means the Hasselbeck's triangle, right? Hasselbeck's triangle. Okay, and it is medial to the inferior epigastric. It reduce upward and straight backward. So okay, the main important thing is that it comes out of the posterior abdominal wall, and the indirect pass through the inguinal canal. Okay, and it is lateral to the epigastric vessels. Okay, so if indirect hernia, they are asking that the hernia is passing through the inguinal canal, and if it is direct, it is passing through the posterior wall, that is the Hasselbeck's triangle. So you can see, if a hernia is traversing through the inguinal canal, through the superficial and deep inguinal ring, if the hernia is traversing, that hernia will be your direct inguinal hernia. Okay, and if a hernia is coming out through the posterior abdominal wall, then that hernia is your indirect. This is your direct inguinal hernia, and this is an indirect inguinal hernia. Okay, so the hernia which will traverse through the inguinal canal will be your indirect inguinal hernia, and the one which will pass through the Hasselbeck's triangle is the direct inguinal hernia. You try to remember that directly from posterior abdominal wall. Okay, and indirect will be traveling through the canal, inguinal canal. Now you know that there is the nerve. Before that, let us see here. Okay, so this one you can see, this is the deep inguinal ring. Okay, and here you have the superficial inguinal ring, and this hernia which is traversing through this, through the deep to the superficial inguinal ring, this hernia is your indirect inguinal hernia. Okay, this is indirect inguinal hernia, and the hernia where you will see in the posterior abdominal wall, that will be your direct inguinal hernia. It will be in the Hasselbeck's triangle. Now sometimes they might ask you about the boundaries of the Hasselbeck's triangle. Okay, so you know that the base, this is the base of the Hasselbeck's triangle. The base is formed by the inguinal ligament. Okay, lateral border is formed by the inferior epigastric vessels. So you can see these are the inferior epigastric vessels, and the medial border is formed by the lateral border of the rectus abdominis muscle. Okay, so any hernia which is coming out of the Hasselbeck's triangle is the direct inguinal hernia. Okay, is a direct inguinal hernia. Now, the question related to this is that which nerve can get involved, okay, or which nerve can get injured in this in the surgery of indirect inguinal hernia. What do you mean by indirect? It means that the hernia will pass from the deep to the superficial ring. Now, there are certain nerves related to this region. So, those are the ilioinguinal nerve. Okay, you can see the ilioinguinal nerve, how it is traversing the inguinal canal. Okay, so most likely this nerve is about to get injured in the treatment of your indirect inguinal hernia, the ilioinguinal nerve. Okay, you can see in this image also. Okay, you can see this nerve is the ilioinguinal nerve. Okay, this is the ilioinguinal nerve which is traversing through the inguinal canal. You also have the genitofemoral nerve, and as well as you have the this one genitofemoral nerve, the genital and the femoral branches. It is mostly giving in the genital and the femoral area, and you also have the iliohypogastric nerve, but mostly through the canal this ilioinguinal nerve is traversing. Okay, and it is coming out of the superficial inguinal ring. So when there is treatment of the indirect inguinal hernia, the ilioinguinal nerve is very likely to get injured. Okay, so the answer here will be your ilioinguinal nerve. Okay, so the answer will be your the ilioinguinal nerve. So out of all this nerve, the ilioinguinal nerve is coming out through this canal, and it is very likely to get injured, okay, in the indirect inguinal hernia. And what do you mean by indirect inguinal hernia? Means that the hernia is traversing through the inguinal canal. Okay, so anybody has marked this answer correct, you can reply in the chat. Okay, you can reply in the chat. Okay. Now next a question came. This is also a clinical type question. I don't know in which shift it came, in the morning or in the evening, but this is a clinical question. So the question came as the person was climbing stairs and there was no light, so he suddenly fell. Okay, and he hit an iron nail at the posterior triangle of the neck. First important thing to know that he got hit in the posterior triangle of the neck, and after injury he had difficulty to elevate the shoulder and presented with loss of shrugging. Okay, on the side of the injury, means on the same side. So which structure is most likely to be damaged? So they have given a image where you can see that there is loss of shrugging. There is loss of shrugging on the same side. Okay, there is loss of shrugging on the same side. So which structure is likely to be damaged? They have given the option deltoid, accessory nerve, sternocleidomastoid and long thoracic nerve. So I want in the chat if somebody has attempted this question and what they have marked. Anybody who wants to answer? It can be wrong, you can just give an answer what you have marked in the exam. Anyone? And in which shift did this question come? I have just got it from the recall of students only. So anyone who wants to answer this in the chat can answer. Okay, so here the answer, how will you get the answer? So you get to know that it is the injury is in the posterior triangle. It is in the posterior triangle. Okay, so you know that a very important nerve related to the posterior triangle is the accessory spinal nerve. Accessory spinal nerve. Okay, so the answer should be accessory nerve. Okay, because if there is injury to this nerve, then the trapezius muscle will undergo atrophy. Okay, and then there will be loss of shrugging on the ipsilateral side, means on the same side, and the difficulty in elevation of the arm. Okay, so most likely the answer should be your accessory spinal accessory nerve. So you can see here that you can see this nerve in the posterior triangle. Okay, the spinal accessory nerve, it can be easily get damaged, and if this is injured, so there will be the trapezius palsy. Okay, so what will happen, the shoulder will drop on the same side, means the sagging of the ipsilateral shoulder. Okay, if there is sagging on the ipsilateral side, same side, means the shrugging is there will be loss of shrugging. What do you mean by shrugging? This is the shrugging, okay. So this is what you mean by shrugging. And if there is loss of shrugging, means there is sagging on the same side. So there will be trapezius palsy, and there will be also weakness in the abduction and elevation. So this is a typical sign of your spinal accessory nerve damage leading to your trapezius palsy. So the answer here will be accessory spinal nerve, okay. Anybody who has attempted this can reply in the chat, okay. Or if the question came different, you can also reply. If it is in a different way, that also you can write in the chat, okay, if you can recall. Okay, now the next question is identify the mark structure. Now this is the mark structure, the green color arrow, okay. This is the mark structure. So can you identify, anybody from in the chat who can identify this structure? Anyone who can identify the structure can write in the chat. Okay, what is this? So you can see that there is an arrow here. Okay, what are the organs and what are the structures? Okay, any ligament? Anyone who wants to answer this in the chat? Okay, so they have given the options like lesser omentum, greater omentum, lienorenal ligament and gastrosplenic ligament. Okay, so what can it be? So before going to the answer, let us see the cross section. This is at the cross section of your T12 vertebra. Okay, it is at a level of T12 and you can see the structures here. So there is this liver. Okay, you can see the liver. Okay, you can see the stomach, the liver, the kidneys. Okay, and this is a spleen. This is the stomach, this is the spleen. Now there are two ligaments, okay, attached from the spleen. One is the, you can mark with the green color, the one which is going towards the stomach, okay, the one which is going towards the stomach. The one which is going towards the stomach, this is the gastrosplenic ligament, okay, this is the gastrosplenic ligament. And the one which is going towards the kidney, the light green color, okay, this is the lienorenal ligament. So from spleen to the kidney, if you can see a ligament, a connection, and they have given the pointer on that, then it is the lienorenal ligament. Okay, you can also see another ligament here, that is the falciform ligament, okay, from the liver. Okay, and then this area is the lesser omentum. This is the lesser omentum. All right, and this is the greater sac. This area is the greater sac. This is the greater sac. Okay, so if you see in this image again, so you know that this is the liver. Okay, this is the liver. This is stomach. ये क्या है? ये है spleen. Spleen. These are the kidneys. These are the kidneys. Okay. This is the lesser omentum. Okay. Here you will get the falciform ligament. Okay. Now the mark area was this one, and this is your lienorenal ligament. Okay. This is your lienorenal ligament. And you can also see a gastrosplenic ligament here. Okay. So if you go back and see here, so they have marked this area, है ना, and this area is your lienorenal ligament. So because you can see the spleen, and this is the spleen, and this is the kidney. So in between these two, the ligament will be the lino-renal ligament. So the answer will be your lino-renal ligament. Okay, the answer will be lino-renal ligament. Okay. Next we'll go to another question. This has been taught to you in my previous session. Okay, the first session I took on the lower limb part 1. I have told you again and again that Trendelenburg sign has been repeated in so many years. So there is a high chance you might get a question on this. So I have told you many times. I don't know how many of you have attended that session of mine, but 3 or 4 common topics came from that session. Okay, the posterior tibial artery, the Trendelenburg sign. Okay, even from the neuroanatomy certain questions came. Okay, the subdural hemorrhage and all. So many questions came common from the sessions I took because it was a repeated questions. Okay, I focus mostly on the repeated questions, and I'm telling again and again. Then they are giving this repeated question in different form. Okay, they are not repeating the same way, but they are modifying it and giving in different forms. So when you see a question which has been repeated twice or thrice, then you have to study the whole topic, not only that question which has been asked. Okay, so in this question they have told that a patient who came to the OPD showed the following gait given in the picture. What is being examined at the hip joint? Okay, so this is a typical gait. Okay, that is the Trendelenburg sign positive, and the gait is your lurching gait. Okay, lurching gait and Trendelenburg sign positive. Now they have mentioned adduction, flexion, extension and abduction. So what is being observed at the hip joint? So anybody who has attempted this question? Anybody who has attempted this question can reply in the chat. किसी ने भी attempt किया है ये question को? क्या हो सकता है answer of this? So before this, let us see about the Trendelenburg sign. So we know that in normal, okay, in the normal pelvis, you know that the gluteus medius and the gluteus maximus are contracting and keeping in a normal stable position. So if a leg is off the ground, so on the opposite side, medius and minimus is contracting and it is tilting the pelvis up. So if there is paralysis on this side, then there will be sagging on the opposite side. Okay, that is what we studied about the Trendelenburg sign. Okay, then you know that the nerve supply is the superior gluteal nerve, and you know what is being observed. So they are mostly this sign is mostly for your abduction of the hip joint. Okay, so you can see the abduction, how the hip joint is abducted. Okay, so this sign is used to observe the abduction of the hip joint, abduction, abduction of the hip joint. Okay, so you know about the entire Trendelenburg sign, and you also know that it is for the abduction of the hip joint. Okay, so same thing we have studied about the Trendelenburg sign. You can see the lurch is towards the affected side, and if there is bilateral Trendelenburg sign positive, then the gait will be your waddling gait. So if there is unilateral, then it is your lurching gait, and if it is bilateral, then it is your waddling gait. So that is all about the Trendelenburg. And if they have mentioned about the gluteus medius and minimus, out of 2, if you have to choose one, then the answer will be medius. If they have asked about the nerve supply, then you know that it is superior gluteal nerve. And if they have asked about the movement, so it is the abduction of the hip joint. So the answer here will be your abduction of the hip joint is observed in the Trendelenburg sign. Okay, so this is the correct answer. Anybody who has attempted this can write in the chat. Okay, now let us go to the next question. We have seen about Trendelenburg. I have been telling you again and again that this is to come. So next time in December session also you might get a question on Trendelenburg, but in a different form. Okay. Now a question came on the arch, pharyngeal arch artery. Okay, which structure develops from the sixth pharyngeal arch artery on the left side? So you have to listen it properly. They have mentioned sixth pharyngeal arch artery on the left side. So you know that these are the pharyngeal arches, and they have mentioned about arch of aorta, ductus arteriosus, common carotid artery, and subclavian artery. So anybody who has attempted this question can answer in the chat who has tried to attempt this question. It's very easy. It's from embryology, and you know that this type of question gets repeated each and every time. The question on the pharyngeal arch artery, the pharyngeal arch pouches and the pharyngeal arch artery. Every time you get a question from that embryology part. So anybody who has attempted this question can answer in the chat. I'm not getting any answer in the chat, so nobody has attempted or what? It's very easy. So you know that the arch artery and the derivative. So you have to remember this table. So you know that from the first arch artery, the artery developed is your maxillary artery from the first arch. From the second, you know that it is hyoid and stapedial arteries. From the third arch, the arteries developed are your common carotid and internal carotid. From the fourth arch, aortic arch is on the left side and subclavian artery is on the right side. And from the sixth arch, which is the question this time, so the answer is ductus arteriosus on the left side and pulmonary artery on the right side. Okay, PR and DL. Delhi. DL for Delhi. So ductus arteriosus, Delhi people, you should remember this. The ductus arteriosus is on the left side and pulmonary artery is on the right side. So from the sixth arch, they have mentioned on the left side. So left side, the answer is DL. That is ductus arteriosus on the left side. So the answer here will be ductus arteriosus. And they have also given the sixth arch, okay, with the image. So the answer is very easy, ductus arteriosus on the left side. So anybody has attempted this question? It's very easy. Actually, these are direct questions which you are getting. Okay. So let us go to the next question, that is, during surgical procedure in the ear, the surgeon injured a nerve, okay, and for which the patient presented with the leg ophthalmos, okay, after surgery, which nerve is most likely to be damaged. So they have given fifth, sixth, seventh and third cranial nerve. So mostly anybody who has tried to attempt this question can answer in the chat. Okay, anyone who is likely to mark it correct. So this is the answer is your seventh cranial nerve. And why the answer is travel? Because leg ophthalmos is mostly due to the damage of the facial nerve, okay, and this will result in infiltration and secondary atrophy of the facial nerve and the orbicularis muscle. So you will observe the facial nerve leg ophthalmos, okay, mostly due to the injury during the ear surgery. There might be injury of the facial nerve leading to the leg ophthalmos. So the answer is your facial nerve, that is the seventh cranial nerve. Next, this is also a question which I have taught in my last session. Okay, I have told you again and again. I begin my slide with this first 2-3 slides of this type of questions. Okay, the Therian, the anterior fontanelle, the Bregma, Asterian, and also see a question came immediately on that only. So I wanted to know if anybody has attempted this question. It was very easy. Anyone in the chat who is willing to answer this? Okay, so the question was, a mother was touching the scalp of her child Okay, she was touching the scalp of her child, and it felt like something was open. Okay, in the anterior part something was open. So they have given what is the probable age of the child. So mostly the question was the anterior fontanelle closes at what age. You know that it remains open till a certain age. So you can see this depress, okay, the open anterior fontanelle, which is a diamond shaped structure in the anterior most part, okay, between the sagittal suture and the coronal suture, okay, on the anteriormost part. When it ossifies, it becomes the bragma, as I already told you. Okay, when it ossifies, it becomes a bragma, and this was also taught in the previous slide. So they have told that the mother was touching and she felt it was open, means it has not ossified. So what is the probable age? So they have given 4 to 7 months, 8 to 13 months, 10 to 12 months, and 13 to 24 months. So anybody who has attempted this question can answer in the chat. Anybody who has attempted this question can answer in the chat. So before this, let us study what is anterior fontanelle. Okay, so it is like it is the when the sutures, you know, the sagittal sutures and the coronal sutures do not get fused. Okay, so they present certain opening in the skull. Okay, the fontanelle is a certain opening in the skull due to the non-ossification of the sutures. Okay, the non-fusion of the sutures. So this is the anterior fontanelle, which is a diamond shape, and this is the posterior fontanelle. Okay, now it is mostly membranous, and it closes at the age of 18 to 24 months. Okay, so it closes at the age of 18 to 24 months. So the last limit is 24 months and the initial limit is 18 months. Now it is largest among the 6 fontanelles, and its delayed closure is mostly due to your increased intracranial pressure, hypothyroidism, and skeletal abnormalities. And if there is a premature closure, it is known as your craniosynostosis. Well, this is about the anterior fontanelle, and the posterior fontanelle closes at around 2 months. Okay, now easy way to remember this is that you try to remember 1.5 year and 1.5 month. So this is posterior, this is anterior. 1.5 year means your 18 months. Okay, and this is around 1.5 month to 2 months, the posterior fontanelle. So it's very easy to remember this technique, that 1.5 month is the posterior fontanelle. So the posterior fontanelle closes first, and the anterior fontanelle is 1.5 year, that is 18 months. Okay, the 18 to 24 months, but you can remember that 1 year is 12 months and half year is 6 months, so 18 months. Okay. So anybody now who can attempt this question in the chat, what will be the probable age of the child? Anyone in the chat who wants to answer this? So as I told you 1.5 year, okay, 1.5 year, that is around 18 months. Okay, so the closure starts from the 18 months. Okay, but before that it is open. Okay, before that it is open. Okay, but they have asked the question that anterior fontanelle, the probable age of the child at which it closes. Okay, the question was at which it closes. So they have asked what is the probable age of the child at which it will close, at which it closes. So the answer should be around 18 months. Okay, but they have given the option 4 to 7, 8 to 13, 10 to 12. So सबसे जो match हो रहा है, that is your 13 to 24 months. So 18 months comes inside this range. Okay, 18 to 24, we know that 18 to 24, but if it is not in option, so they have given 13 to 24, तो इसके range में आ जाता है. ठीक है. So the question was what is the probable age of the child at which the fontanelle closes. ठीक है. So the answer was your 13 to 24 months. अगर 18 to 24 भी था तो that is also correct. Okay, I don't know what was the exact option. From the recall they have told about 13 to 24, but if the option was 18 to 24, it is also correct. If it is 13 to 24, 18 months comes in that range, so that is also correct. ठीक है? So that was about the fontanelle. Now next question. Anybody who has attempted this question? A patient has cavernous sinus infection due to which it has involved a nerve which is related on its medial side. Okay, to confirm the involvement of the abducens nerve, you will ask the patient to look towards superior, inferior, medial and lateral. Now this is very easy answer. Anybody who has attempted this can answer in the chat. Anyone who has attempted this question can answer in the chat. So before attempting this question, let us see about the abducens nerve supplying the recti of the eye. Okay, you know that this is the eyeball. Okay, and this muscle is the lateral rectus muscle, and this is supplied by the sixth cranial nerve, that is the abducens nerve. Okay, it is supplied, the lateral rectus is supplied by the sixth cranial nerve, that is the abducens nerve. And you know that these are the movements of the recti. Okay, the extraocular muscles. Okay, so you have lateral rectus, medial rectus, superior rectus, inferior rectus, and superior oblique and the inferior oblique. So the lateral rectus movement is on the lateral side. The medial rectus, the eye, it will try to move the eyeball on the medial side. Superior rectus will elevate and inferior rectus will depress. Okay, so these are the major movements. So you can see in this table. So the medial rectus, they have mentioned the primary movement is adduction, okay, towards the medial aspect. Lateral rectus is abduction. Okay, and then inferior rectus is primary is depression, superior rectus primary is elevation, inferior oblique is excyclotorsion and encyclotorsion of the superior oblique. So these are the primary actions. We are mostly talking about the primary action. And about the recti muscle, you know the dictum that it is your SO4 LR6. Okay, SO4 LR6. So what is the dictum? And others supplied by 3. So superior oblique is supplied by the fourth cranial nerve. Okay, lateral rectus is supplied by the sixth cranial nerve, and all other recti, all other extraocular muscles are supplied by the oculomotor nerve, that is the third cranial nerve. Okay, so the lateral rectus is supplied by the sixth cranial nerve, and lateral rectus primary function is abduction, that is away from the midline. Okay, so that is your abduction, away from the midline, means we'll ask the patient to see laterally, okay, towards the lateral aspect, so that we can see the movement, whether the lateral rectus is working properly or not. Okay, so they have asked, you will ask the patient to look towards, okay, to confirm the involvement of the abducens, means the sixth cranial nerve. We know that SO4, LR6, others 3. मतलब हमको देखना है lateral rectus is working properly or not, and you know that the main primary action is abduction, that is away from the midline. So we'll ask the patient to look laterally. Look towards the lateral aspect so that we can see the functioning of the lateral rectus. So the answer will be lateral. Okay, so the answer will be lateral. Anybody who has attempted this question can answer in the chat box whether it is correct or wrong, or if you have any doubt. Okay, okay. Okay, now this is a very common topic to be studied in the chapter of liver. that is the hepatic segments, and the corneate segments. Most important is the corneate segments. So they have asked identify the marked segment in the image, and they have given this segment. Okay, so anybody who can answer this in the chat, what segment is the marked segment? Anybody who wants to answer in the chat? What is the marked segment? Okay, so here, before answering this question, let us study about the corneate segment. Okay, let us study about the corneate segment. So corneate segment is the hepatic segments. Okay, and there are certain classification of the corneate segments. So you know that there are 8 segments. So you have segment 1 is the caudate lobe, then segment 2, if you compare with the traditional part, then segment 2 will be the superior lateral segment, left lobe superior, segment 3 is the lateral segment, left lobe inferior, 4 is the medial segment of the left lobe, and 5, 6, 7, 8 is from the right lobe. Okay, so these are the segments. So you can see here how the segment started. So the first segment is here, that is the caudate lobe, segment 1. Okay, then you have segment 2, then you have 4A, 4B. Okay, then you have segment 3, then segment 2, 3, 4A, 4B. Then you have segment 5, segment 6, segment 7, and segment 8. Okay, these are the corneate segments. Okay, similarly you can see in this image. So which next time they might ask you which vein is dividing the corneate segments into the right and the left lobe. So the middle hepatic vein, you can see the left hepatic vein supplying the left lobe, the right hepatic vein is supplying the right lobe, and the middle hepatic vein is dividing the entire liver into the right and the left part. Okay, it's dividing the entire liver into the right lobe and the left lobe. Okay, so this is about the middle hepatic vein which is dividing, and then you can see the segments. So this is the caudate lobe, you can see this is segment 1, then segment 2, segment 3, 4A, 4B, 5, 6, 7, and 8. So the answer in the marked question was your segment 8. Okay, that was the segment 8. So you know that middle hepatic vein, as I have already told you, it will divide into your right and left lobe or right and left hemiliver, and the plane will run from your inferior vena cava to the fossa of the gallbladder. Then you also have a portal plane. Okay, so by this phenomenon you can remember. Okay, so you know that the middle hepatic vein is going to divide the entire liver into the right and the left hemilivers. Okay, and then you have a portal plane. Okay, now you know that the lobe 1 will be behind the liver, it is the caudate lobe, it will be behind. Then you have the 2, 3, then 4A, 4B, 5, 6, 7, and 8. So this is how you remember, the corneate segment. Okay, this is how you remember the corneate segment, or you can also put your thumb like this. Okay, instead of this you can just put it like this, and the thumb is your the caudate segment. Okay, and then you have a midline, that is the portal plane. Okay, in the image as you can see you have the portal plane, and then you divide your 4 fingers into your 2, 3, 4A, 4B, 8, 5, and 7, 6. Okay, or you can also remember that 1, and then you can go 2. Okay, you can go in this way. See, 1 have it is behind, then 2, then 3, then 4, then 5, 6, 7, and 8. So it is going in a clockwise direction. Okay, of the right hand, if you are choosing, it is mostly going on the clockwise direction. If you choose on the left hand, it will be anti-clockwise. Okay, so that is how you remember the corneate segment. Okay, that is a corneate classification. So you know that the lobe 1 will be here, it will be the lobe 1. Okay, the segment 1, then segment 2, then segment 3, then segment 4A, segment 4B, segment 5, segment 6, okay, segment 5 and segment 6, then segment 7, and this is segment 8. This will be segment 8. Okay, segment 8, sorry. This will be segment 8. So the answer will be your segment 8. Okay, so the answer will be your segment 8. Okay, so that is how. And this, if next time they mention about this vein, this will be your middle hepatic vein, which is dividing the entire lobe into the right and the left hemilever. Okay, that will be the middle hepatic vein, as you can see here. Okay, so the answer here will be segment 8. Okay. Okay, let me go to the next question. Anybody who has any doubt can ask me in the chat. Okay, so the next question is, during the surgical procedure of patent ductus arteriosus, the structure which is in close relation to it can be damaged. Okay, what can be the structure? So they have mentioned about the vagus nerve, the phrenic nerve, the recurrent laryngeal, and the spinal accessory. Now among these two nerves are completely wrong. That is phrenic, it is out of no way, the spinal accessory out of no way. Now you have confusion between the vagus and the recurrent laryngeal. Now let us see which will be the correct answer. So you can see here, okay, these are the dorsal aorta and aortic arches. You can see here. This is the left vagus nerve. Okay, this is the left vagus nerve. This is the right vagus nerve. It is giving the right recurrent laryngeal, and left is giving the left recurrent laryngeal. Okay, the left recurrent laryngeal, and then you can see the ductus arteriosus at this region. Okay, as it is connecting here. So the ductus arteriosus is here. Okay, and the nerve which is related to this ductus arteriosus is the left recurrent laryngeal nerve. Left recurrent laryngeal nerve. Okay, so even next time they ask about the ligamentum arteriosum. So they might ask you next time. This time they have given about the patent ductus arteriosus. Next time they will give a question on the nerve which is related to the ligamentum arteriosum. So that nerve will be your left recurrent laryngeal nerve. Okay, left side recurrent laryngeal nerve, and on the right side you can see that this is the right vagus, and it is how winding around this right subclavian artery. Okay, the right is winding around the right subclavian artery, and this is closely related to the ligamentum arteriosum and ductus arteriosus. So you can see in this image as well. Okay, so you can see this is the patent ductus arteriosus. Okay, this is the PDA, that is the patent ductus arteriosus, and the nerve related to it is the left recurrent laryngeal nerve. This is the left recurrent laryngeal nerve of the left side, recurrent laryngeal nerve of the left side. Okay, so the answer will be your they have not mentioned about right or left, but if they would have mentioned, then the answer will be your the recurrent laryngeal nerve. Okay, the answer will be your the recurrent laryngeal nerve. Okay, इस question का answer is recurrent laryngeal nerve. So any doubt you can ask in the chat. अगर किसी ने ये वेगस अटेम्प्ट किया है या फ्रेनिक or anything, you can answer in the chat or you can ask in the chat. Okay. Now many question came on the karyotyping, okay, from the genetic session. Okay, you got many questions on the karyotyping. Karyotyping में बहुत कुछ आया है. So anybody who remembered it, karyotyping, anybody who has attempted this correct can answer in the chat. Okay. Okay, so they are given identified a disorder in the given karyotype. So here you can see that they have marked the chromosome number 18, and the chromosome number 18 you can see trisomy. Okay, you can see the 3 chromosomes. So there is trisomy 18. So this is the answer is trisomy 18. Very easy. If they gave you a question like this, direct question, I don't know what type of question came, but from the recall, just I'm saying, from the students who have recalled it. So if you can see the karyotype, and if you see in 18 number, you see 3 chromosomes, then it is trisomy 18. Now what is trisomy 18? Anybody in the chat who knows what is trisomy 18? Anyone? You should know this. Trisomy 18, trisomy 13. We'll discuss about all the trisomies in the next slide, about 8, 18, 21 and 13. Because every time they're repeating this on a repeating basis, like this time in July, next time in December session, they will repeat trisomy 8 or trisomy 21 or trisomy 13. Even in the morning and evening, they are repeating this. So anybody who knows what is 18, trisomy 18? Anyone who wants to answer what is trisomy 18? What syndrome is trisomy 18? Anybody? किसी को नहीं मालूम what is trisomy 18? What syndrome is trisomy 18? Nobody knows this. So let us come to a syndrome which is known as the Edwards syndrome. Okay, so very easy. 18 is Edward and 13 is Patau. ठीक है, 18 is Edward and 13 is Patau syndrome. Okay. Now in Edwards syndrome, what are the prominent features? So you will have a prominent occiput. So the occiput will be very prominent. Okay, you will have a prominent occiput. The ears will be very low set. Okay, they will have low set ears. Typical clenched hands with overlapping fingers. Okay, typical clenched hands with overlapping fingers. There will be heart defects. There will be micrognathia. Okay, small mouth, micrognathia, renal defects and limited hip abduction. So these are the typical clinical signs and symptoms of Edward. You try to remember 8. Don't think that trisomy 8 is a different way, but among Edward and Patau, Edward, okay, so it is 18. Okay, and Patau is your 13. Okay, Edward is your 18 and Patau is your 13. These are the 2 trisomies asked alternately each year in each session. Okay, so if you have micrognathia, prominent occiput, low set ears, clenched hands, okay, heart defects, renal defects and limited hip abduction, and there is trisomy on the 18 chromosome. As you can see, this is trisomy on the 18 chromosome, then it is your trisomy 18, that is your Edwards syndrome. Okay, it is your Edwards syndrome. Okay, the next trisomy is the trisomy 13, that is the Patau syndrome. Okay, so 13 number may you will have trisomy, as you can see in this karyotype. Okay, so in the 13 number you will have the trisomy. Okay, so this is Patau syndrome, trisomy 13. ठीक है. So this is Patau syndrome. Now what is important about the Patau syndrome? The most important feature, you will get either cleft lip or cleft palate. Okay, you will get cleft lip or cleft palate. Clenched hands can be found in both Edward and Patau. The eyes will be closely set. Okay, and it might eventually fuse together. Then you might have decreased muscle tone. You might have an extra finger or toes. You might have an extra finger or toes. Okay, you might have an extra finger, toes, hole split or cleft in the iris as well. So you might have a cleft in the iris, low set ear, mental retardation, scalp defects, missing skin might be there, small head, small eyes, and small lower jaw. But important is your cleft lip, cap palate, and extra fingers and toes. Okay, so that is trisomy 13, that is your Patau syndrome. Okay. Next is your Down syndrome, that is trisomy 21. So 21 number में you have trisomy. This is the trisomy 21, that is the Down syndrome. So Down syndrome, you have mostly seen some patients of Down syndrome in the pediatric OPD as well. So you will have eyes slanting up with palpebral fissures. You can see epicanthic fold, okay, that skin fold of the covering the inner corner of the eye. So you get epicanthic folds, you will get low set ears, the enlarged tongue, okay, low nasal bridge and the dorsum. Then small stature, also low muscle tone, gap between the first and the second toe, important. This is important, gap between the first and the second toe. Abnormal and excessive facial fat distribution, delayed growth, mental retardation will be there. Broad hands with short fingers, and very important, you will have a single deep crease in the hand and simian crease. It is known as the simian crease, okay. It is known as a simian crease. It's a typical of Down syndrome, simian crease. Whenever they will mention about Down syndrome, they will mention about the simian crease, single crease in the palm. So they will definitely, they are going to mention about the simian crease. And if you see the simian crease, then you have to tick mark this Down syndrome. And also you have to see that it is trisomy 21. Okay? What about the trisomy 8? Trisomy 8 mosaicism. Okay, it's rare but occurs. Okay, so this is trisomy 8 mosaicism. Okay, and it is also known as the Warkani syndrome. Okay, the trisomy 8 mosaicism or Warkani syndrome. Nowadays they used to ask on trisomy 8 as well. Okay, they are also asking the uncommon questions. So trisomy 8 mosaicism or Warkani syndrome. Mostly you will have the prominent forehead, deep set eyes, hypertelorism with broad nasal root, prominent ears. You will have a camptodactyly of the second and through the fifth fingers and toes. Okay, as you can see here. Okay, this is the camptodactyly. Okay, deep plantar and palmar crease, and the deep plantar creases are highly characteristic of this condition. So you will also have deep creases. So this is your trisomy 8 mosaicism or Warkani syndrome. All right. Okay. Now another question as recalled by the student: cleft lip and cleft palate is found in. So anybody who wants to answer this in the chat? Just now we have read about the cleft lip and cleft palate, which is very typical. Okay, somebody has mentioned that no option like ilioinguinal nerve. So can you mention like what they have given in options, if you remember, in the indirect inguinal hernia, or क्या option था? If you can remember, kindly mention in the chat. So as I got from the recall, somebody told that ilioinguinal nerve was there. अगर नहीं है तो क्या क्या option था? You can recall and write in the chat. So I may rectify the options, okay, whatever options was there. But if there was ilioinguinal nerve mentioned, the correct answer is ilioinguinal nerve. अगर नहीं है तो what was the other option? If you can kindly mention it, can I can rectify that question, okay. अगर ilioinguinal nerve was not there in indirect hernia, as somebody mentioned in the chat, so you can mention if you remember what was the option in that question, indirect inguinal hernia. अगर options याद है तो हम लोग correct answer ढूंढ सकते हैं उधर से, ठीक है. So that's about okay. So anybody can answer this cleft lip and cleft palate is found in. ये कहाँ मिलता है? अभी just now we have studied cleft lip and cleft palate. If they had given trisomy 8, trisomy 18, trisomy 21 and trisomy 13, among these which is the one you will tick mark for cleft lip and cleft palate? अभी हमने we have studied about Patau syndrome, and the very typical feature of Patau syndrome is the cleft lip and cleft palate and the extra fingers and toes. So if they have given typical about cleft lip and cleft palate among all the trisomies, then you have to mark the answer trisomy 13. Okay, trisomy 13. That is your Patau syndrome. Okay, that is Patau syndrome. Okay. So yeah, in the chat, if anybody remembers the option for the indirect inguinal hernia, क्या option आया था, you can mention in the chat. So can we, so that we can attempt the correct answer. Okay, अगर ilioinguinal nerve नहीं था तो क्या nerve था? You can just mention that. Okay, अगर नहीं था तो what was the other nerve written there? Okay. So identify the type of, you also get ilioinguinal and iliohypogastric nerve together. So is the mention of iliohypogastric was there with the ilioinguinal nerve, as you can see in this question as we have discussed. So these are the probable nerves. Okay, so as you can see here, this is the ilioinguinal nerve, as I thought that it might have come. Okay, and another nerve which you can see is the iliohypogastric as well. Okay, so you can also see the iliohypogastric nerve. The iliohypogastric nerve, okay, which is going in close contact in the inguinal canal, and if it is going in the base एकदम deep, then it is the ilioinguinal. ठीक है, तो इनमें से अगर कोई ऑप्शन एक था, you can rectify it, the ilioinguinal or iliohypogastric. Okay, so iliohypogastric bhi, it is in close proximity, and ilioinguinal is also in close proximity, but the genital branch of the genitofemoral nerve, okay, and the obturator nerve, this is completely no. Okay, the femoral nerve is also no, and the genitofemoral nerve is also no. So in the ilioinguinal, if they have mentioned about the iliohypogastric, at least that might be also correct. Okay, so just rectify this. If you remember the options, you can write in the chat so that we can correct it. Okay. Okay. Okay, so if there is cleft lip and cleft palate, particularly they have mentioned typically about cleft lip and cleft palate, then if you have the following options where you have trisomy 18, 13, 21 and trisomy 8, then mark the answer as Patau syndrome. Okay? Okay, 13 is Patau, 18 is Edward, 21 is Downs, and 8 is Warkhani syndrome or trisomy 8 mosaicism. Okay? Now, this was the slide which I was about to teach in the neuroanatomy part 2. Okay, so it will be taught in my next session, that is neuroanatomy part 2, where I am going to teach you about all the CT scans of different type of hemorrhages, that is your extradural, the subdural, the subarachnoid and the intracranial. Okay, what are the CT scans and how to identify that, and what are the typical shapes of those scans. Okay, it mostly comes in the radiology, but it you also have the radiological anatomy part. So there was a clinical history given, and they had mentioned about a type of hemorrhage in the given scan, and they had given the CT image of the hemorrhage. So in this typical image, what can you observe? They have given this hemorrhage. Okay, this is a typical hemorrhage they have mentioned. What is this hemorrhage looks like? How do this hemorrhage looks like? What is the shape of this hemorrhage? Anybody in the chat who wants to answer this? What is the shape of this hemorrhage? So before going to this, let us study about the difference between the epidural and the subdural. As I told you in my previous neuroanatomy class, so you have the dura mater, okay? You have the dura mater, okay? The arachnoid matter and the pia matter, and then the braid. So the pia is the deepest and the dura is the outermost meninge. Above the dura, it is the epidural, above the dura, epidural or extradural. Below the dura, that is known as subdural. Okay, so subdural space is between the dura and the arachnoid matter. Okay, below the dura, that is the subdural space. Above the dura, that is the epidural space. Okay, now between the arachnoid, after that you got arachnoid matter below. Below the arachnoid you have the subarachnoid space. Sub मतलब below. ओके उसके बाद आ गया पाया मैटर एंड पाया के नीचे डायरेक्ट ब्रेन है एंड उसके नीचे भी एक छोटा स्पेस है विच इज नोन एज सब पायल स्पेस बट इज नॉट रिक्वायर्ड नॉट दैट इम्पॉर्टेंट. सो फॉर यू टू रिमेंबर दैट यू नो दैट ड्यूरा मैटर, ड्यूरा के ऊपर है एपिड्यूरल, ड्यूरा के नीचे है सब ड्यूरल. एरेक्नॉइड मैटर के ऊपर है योर सबड्यूरल, एरेक्नॉइड मैटर के नीचे है सब एरेक्नॉइड. ठीक है, सो ड्यूरा के ऊपर है एपीड्यूरल और एक्स्ट्रा ड्यूरल स्पेस एंड ड्यूरा के नीचे है योर सबड्यूरल स्पेस. सब मीन्स बिलो. एरेक्नॉइड मैटर के नीचे है सब एरेक्नॉइड स्पेस वेयर यू गेट द CSF. ठीक है, नंबर पंक्चर हम लोग करते हैं सब एरेक्नॉइड स्पेस. ऑलराइट, okay. That also you know that these meninges are also continuous in the spinal cord and the dura mater is continuous, or the subarachnoid space and the dura mater is continuous up to the lower level of the S2 vertebra. ठीक है. Okay, so here they have mentioned about the epidural hematoma and the subdural hematoma. So epidural hematoma, between epidural I told above the dura, okay, so the outer endosteal layer of the dura mater, okay, it is between the skull and the outer endosteal layer of the dura mater. So you can see here, if there is a fracture in the skull, and then this blood is deposited outside the dura, okay, outside the dura mater. Okay, this blood is deposited outside the dura mater. This blue color is the dura mater. Okay, blue color is the dura mater. Here also this blue color is the dura mater. So epidural means the blood will be outside the dura mater, that is between the skull and the outer endosteal layer. Okay, and most likely you know that terion, okay, that H-shaped suture in the head where the four bones are fused, okay, that region, terion, if there is a blow, then you injure an artery in that region and that artery is the middle meningeal artery. Okay, middle meningeal artery. So middle meningeal artery hemorrhage will lead to your extradural hematoma or extradural hemorrhage. So extradural hemorrhage or extradural hematoma is mostly due to the damage of the middle meningeal artery. Okay. There will be lucid interval followed by unconsciousness. Okay, so you know that what is lucid interval, so it will be followed by unconsciousness, then talk or die. Okay, and in the CT scan, in the extradural hematoma, you will see a biconvex lens like structure. Okay, biconvex shape. Okay, the hematoma will be biconvex in shape. Okay, this is in the epidural or the extradural. Okay, you will see a large biconvex shape hematoma, mostly due to the damage to the middle meningeal vessels. Okay, and you will have lucid interval followed by talk or die. Okay, and this is between epidural means dura ke bahar. Okay, outer between the skull and the outer endosteal layer of the dura. Subdural, I told that this is a dura mater. Sub means below. So subdural means below the dura mater. So between the dura and the arachnoid. Okay, now In the subdural hematoma, mostly you will have the venous blood. Mostly you will get the venous blood because here the bridging veins which drain brain to the dural venous sinuses, the bridging veins are injured. Okay, in the epidural, mostly in the Terrian region, if there is a blow, the middle meningeal artery is ruptured due to skull fracture, that is epidural, and due to bridging veins, you have the subdural hematoma, and that is mostly due to venous blood. Then there will be gradually increasing headache and confusion. Okay, and very, very important is that you will have a crescent shape. Okay, you are going to have a crescent shape, as in here you got the crescent shape. You will have a crescent shape scan. Okay, you will have a crescent shape hematoma, crescentric. Okay, what happened to this? Yeah, so you will have a crescent shape hematoma. Okay, you are going to have a crescent shape hematoma in the subdural scan. Okay, so here also you can see that it will be your biconvex, and this will be a crescent shape like half moon. Okay, it will be like crescent shape. Okay, in the subdural hematoma. Okay, so in the question you can see that there is no skull fracture. First and foremost, you can see no skull fracture here, because if there is the epidural hematoma, there will be a big hematoma that is biconvex. Okay, and there will be a skull fracture involved. Here there is no skull fracture, and you can see a semilunar crescentric shape hematoma. Okay, a semilunar crescentric shape hematoma, and that's why the answer is your subdural hemorrhage. Okay, it is subdural hemorrhage or subdural hematoma. Okay. Okay. Now this question I have already told you in my second session. Okay, in the lower limb second session, that posterior tibial artery is going to come every time it is repeated. Either you will get a posterior tibial artery question or you will get a dorsalis pedis question. So in December also you are going to get either of the any of the either question, and they might change the pattern of the question, but they might ask the same posterior tibial artery palpation, like they have asked about the Trendelenburg sign. So they have changed the pattern of the question. So this posterior tibial artery also, they might change the pattern and ask to you. Okay, so it is repeated again and again. The examiner is palpating which artery in the following image. So you can see here that it is behind the medial malleolus. This is the medial malleolus. It is behind the medial malleolus, and on the टेंडोएक्यूलिस के medial margin के बीच में he is palpating between the medial malleolus and टेंडोएक्यूलिस. So that is your posterior tibial artery palpation. ठीक है, it is the posterior tibial artery palpation. So I have told you that how to see the posterior tibial artery. तो ये सबसे important है that it is palpated 2 centimeter below and behind the medial malleolus and in front of the medial border of the टेंडोएक्यूलिस. So टेंडोएक्यूलिस के in front में और medial malleolus के behind में you will have the posterior tibial artery palpation. ठीक है, you will have the posterior tibial artery palpation. So this is, again you can see here, this is the medial malleolus, behind the medial malleolus and between the posterior टेंडोएक्यूलिस. Here you will get the artery, that is the posterior tibial artery. So, and you will ask the patient to invert his leg. So next time the question might come on the position also. So you will ask the patient to invert his leg while observing the posterior tibial artery pulse. ठीक है? ये बार बार आ रहा है, तो इन डिसम्बर ऑल्सो वेरी लाइकली यू माइट गेट दिस क्वेश्चन बट इन अ डिफरेंट पैटर्न, ठीक है. और यू माइट गेट अ डॉर्सलिस पेडिस ऑल्सो. पेरिफेरल पल्सेस कुछ भी आ सकता है. इधर यू माइट गेट पोस्टीरियर टिबियल, यू माइट गेट अ पोप्लिटेल आर्टरी, और यू माइट गेट अ डॉर्सलिस पेडिस आर्टरी, ठीक है. Okay. Now, anybody who has attempted this question, this is a question on fall on outstretched hand. Anyone who has attempted this question can write in the chat. Okay, so a person fell on an outstretched hand where the probable fracture is given in the X-ray. So ये क्या fracture हो सकता है? So you know that fall on the outstretched hand. जब outstretched hand से गिरते हैं, so most likely the bone which gets fractured is the scaphoid. Okay, I want to tell before that, before going to the X-ray, you should know that on fall on an outstretched hand, the most likely the bone which is getting fractured is the navicular. It is a navicular fracture. Okay, it is a scaphoid or a navicular fracture, and this scaphoid will break into very small bones. Okay, then this fracture mostly occurs after fall on a outstretched hand. Okay, and symptoms will typically involve swelling and pain in the wrist below the base of the thumb. Okay, so you can see here how the scaphoid is getting fractured on fall on the outstretched hand. Okay, now here you can see in this image there is a hairline, not hairline, there is a good fracture here, this area. Okay, and this is a scaphoid. Okay, this is a scaphoid bone. Now before knowing that, you should know how to name the carpal bones. Carpal bones naming कैसे करते हैं? So you should know that. So you can see here in this X-ray, okay, so you can see here in this X-ray, first of all you get oriented yourself, so you know in the anatomical position that your radius is on the lateral aspect, ulna is on the medial aspect. So this is the radius, this is the ulna, so this is the medial aspect, this is the lateral aspect. Okay, after that you know there is a mnemonic. You know the mnemonic? I hope everybody knows the mnemonic. So it is she looks too pretty, and next row is try to catch her. ठीक है? See, she looks too pretty, try to catch her. She is on the lateral aspect, pretty is on the medial aspect. Again, try is on the lateral aspect and her is on the medial aspect. Now, she for scaphoid, look L for lunate, trapezium, and triquintral and pisiform. And for the tri, you have trapezium, trapezoid, capitate, and hamate. Okay, from lateral to medial. Now, similarly, you can see in the proximal row. You can see in the proximal row that you have the scaphoid bone. Okay, she looks. Then you have the triquintral. Okay, and then you have the pisiform bone. Okay, so she looks too pretty. Okay, this is in the proximal row, and this is from lateral to medial. And then you have trapezium, okay, the trapezoid, the capitate, and the hamate. Okay, so you have trapezium, trapezoid, capitate, and hamate. Okay, so she looks too pretty, try to catch her. Okay, that is the mnemonics. That is try to catch her. Okay, so first of all you see the X-ray and get oriented yourself which is lateral and which is medial. So you see the radius bone, you can see the styloid process here. So by that, even if it is not given, you can see the styloid process of the ulna, है ना? So this is the ulna, it is on a medial aspect, and this is the radius on the lateral aspect. Then you can see the mnemonics that she looks too pretty. First of all, you have the scaphoid, then you got a lunate, then triquintral, and then the smallest one is the pisiform, which looks like a P. And uske upar you have the trapezium, trapezoid, then the capitate and the hamate. ठीक है? Okay. Now, in that given X-ray, there was a fracture, okay, and that is the scaphoid fracture, which was due to the fall on the outstretched hand. ठीक है? Fall on the outstretched hand leading to your scaphoid fracture. Okay, so I already told you, if there is a fall on the outstretched hand, the most likely the bone to be injured is the scaphoid bone. The type of fracture is a navicular type of fracture, and there will be swelling and pain just below the base of the thumb. Okay, so you might next time get a question with the symptoms as well. Okay, so the answer here will be, here you can see there is a fracture in the scaphoid. This is the scaphoid bone. Okay, so the answer will be your scaphoid. Okay, the answer will be your scaphoid. Okay. Now let us go to the neuroanatomy part, and this is also in my next neuroanatomy part 2 I am going to teach about. I think in the part 1 I have already explained about this. Okay, I have explained about the caudate nucleus, the putamen and all, everything about the internal capsule. Okay, and okay, so let us see the mark structure in the internal capsule. So you can see here that they might ask you a CT scan, or they might give you a specimen. So I don't know what came in your exam, whether it is a scan or a specimen, but let us attempt this answer. So before that, let us see that if you get a specimen, then this area is the internal capsule. Okay, so you have the anterior limb of the internal capsule, you will have the posterior limb and the genu, and then in the above part you will get the head of the caudate. Here you will have the head of the caudate. This is the lentiform nuclei. So this part is the globus pallidus, this is the putamen. Okay, and then below that you will get the thalamic nuclei. Okay, so this, if they have mentioned about this area, then it is the internal capsule. Okay, so you have the internal capsule, and then outside you will also have the external capsule as well. Okay, similarly you can see here, this area is the internal capsule. Okay, then you have the lentiform nucleus where you will have the globus pallidus and the putamen. Okay, and then you will have the thalamus and the caudate nucleus, and outside that you will have the external capsule. ठीक है, और उसके पहले before the external capsule, here you can see a structure. This structure is the claustrum. ठीक है, you can also see the claustrum. Okay, so most probably the question came on the specimen. I hope it came on a specimen, and if they have marked this as such, so you know that this is the internal capsule. है ना? This is the internal capsule. So you have the anterior limb, you have the posterior limb, and you have the genu. ठीक है? Even if they give a scan here, so you know that this is the internal capsule. Okay, you will have the caudate nucleus here, you will have the lentiform nucleus here, and the thalamic nucleus here. है ना? So whatever the question came, they have mostly given the arrow on the internal capsule ka specimen. Okay, so the answer will be your internal capsule. ठीक है, the answer will be internal capsule. Okay, so here also in the scan I have shown you, as you can see, so the genu of the corpus callosum can be seen here, and then you have the limbs. Okay, you have the anterior limb, you have the posterior limb, and you have the genu of the internal capsule. Okay, so this part is the internal capsule. Here you will have the caudate nucleus. Okay, then you will have the lentiform nucleus here, and below you will have the thalamus. Okay, so that is how they have mentioned it. Okay, so they might give you, if they have asked the specimen in the July session, in December they might ask about the scare also. So you should know the internal capsule, external capsule, the caudate nucleus, globus pallidus, lentiform, thalamus, everywhere in the scan or either in the specimen. Okay, I have already taught you in the neuroanat part 1. Okay. Now this question has come on the esophageal constriction. So which of the following is present from the central incisor up to 25 centimeter? So they have given the option cricopharynx, arch of aorta, left main bronchus and the diaphragm. So anybody who has attempted this question, anyone who has attempted this question can answer in the chat. Okay, anybody who has attempted this question can answer in the chat. So they have mostly asked about the esophageal, you know that the esophageal constrictions, right? So we know about the vertebral levels and the distance from the central incisor. So if it is 16 centimeter, then it is at the level of the cricopharynx. Okay, 16 centimeter. If it is at the level of your 25 centimeter, 25, it is mostly 25 centimeter, that is T5, then that is your aortic arch. The left main bronchus, that will be at the level of 28 centimeter, and the esophageal hiatus in the diaphragm is at the 40 centimeter. So 16 centimeter is the cricopharynx, aortic arch is 25 centimeter, left main bronchus is 28 and esophageal hiatus is 40 centimeter. Okay, so they have asked about the constrictions. So the answer here will be very easy. It will be your arch of aorta, because arch of aorta is 25 centimeter, left main bronchus is 28, esophageal hiatus is 40 and cricopharynx is 16 centimeter, as we have seen in the table. Okay, so I hope everybody has attempted this question correct. Okay, arch of aorta. Okay, so the next question came on a fracture which occurred in the mark area. Mostly the nasal bridge has been fractured in this area and the patient will present with. So since it is in the nasal area and a nasal bridge has been fractured, so the answer will be related to some olfaction. So answer will be your anosmia out of all. If you see visual, no way. Aphasia, no. Dementia, no. So the answer will be anosmia. Next question they have asked about which ganglia is disturbed due to the nerve involvement located in the mark area. So this area marked, as you can see, I think you should know this area. This is your pterygopalatine fossa. Okay, and just below the maxillary nerve you have the pterygopalatine ganglion. So the answer here will be the pterygopalatine ganglion. Okay, so you can see here they have mostly asked about this area. Okay, and this area is a pterygopalatine fossa. So you have the pterygopalatine ganglion here. Hena, you have the pterygopalatine ganglion, and pterygopalatine ganglion is just below the maxillary nerve. As you can see, this is the maxillary nerve. This nerve is going here through the rotundum. Okay, so just below the maxillary nerve you can see this ganglion, that is the pterygopalatine ganglion. Okay. Okay. Now what are the locations? You can see other locations also. So if you can see the pterygopalatine ganglion in the pterygopalatine fossa here. Okay. Behind that you have the otic ganglion, the ciliary ganglion and the submandibular ganglion. So these are the parasympathetic ganglion. Okay, these are the parasympathetic ganglion. So we should also know about the other ganglions location as well. Okay, So the answer to this is pterygopalatine ganglion. Okay, now we'll study about the histology. So anybody has any doubt can ask in the chat box. Okay, any doubt regarding any question attempted, not attempted, you can ask in the chat box. Okay. Okay, so the mark structure secrete which hormone? So what is the, first of all you have to identify the slide. This is a slide of your thyroid gland. Hannah, this is a slide of your thyroid gland, and you have the colloid field follicles here, as you can see. This these are the colloid, okay, colloid field follicles, and these cells are the follicular cells, okay, lining the colloid field follicles. These are the follicular cells, and in between, in the connective tissue, this group of cells are known as your, what are this group of cells? Anybody in the chat box? This group of cells are known as your parafollicular C cells. As in the name they have C, so the answer is your parafollicular C cells. They are going to secrete your calcitonin. I have already marked the correct answer. So those are the parafollicular C cells secreting the calcitonin. Okay, I hope everybody has marked this option correct. Okay, so you know that, see, these are the, if you can see here, that these are the colloid, okay, and these are the follicles, okay, these are the follicular cells, okay, these are the thyroid follicular cells, and in between you will have the in between this, where there is connective tissue, you are going to have the parafollicular C cells. Okay, then you will have the parafollicular C cells, and these are mostly lined by the cuboidal epithelium, but this differs on the basis of active, hyperactive, and in the resting stage. So and these are the blood vessels you can see here. Okay, so when we are going to study about the thyroid gland in histology in the anatomy section, next few session, then I am going to discuss about histology in a better way. So the answer here is your calcitonin. Okay, now the next question on histology was this slide which was of your adrenal gland. Okay, this was a slide of your adrenal gland. Okay, now they have asked the hormone secreted by the marked area. So they have marked the area here. So you know that the adrenal gland, you have the outer cortex, and the innermost area where you have blood vessel is the medulla. And in the cortex you have certain divisions. So this is the, you know that G, F, R. So you have the zona glomerulosa, zona fasciculata, and zona reticularis. Okay, zona glomerulosa, fasciculata, and reticularis, and then you have the adrenal medulla. Outer that you have the cortex. Okay, so this is the slide. Okay, so if you study properly, so this is the division. As you know, there is a capsule, then you have the, sorry, this is the capsule, and this entire region is the cortex. Okay, this is the capsule, and this entire is the cortex, and inside it you have the medulla. Okay, so this is how there is the division. As you can see, this is the adrenal medulla, the innermost part. The innermost part is the adrenal medulla, and this area is the adrenal cortex. The outermost is the glomerulosa, then the fasciculata, and then you have the reticularis. Okay. Okay, now what are the secretions from this? Okay, so you should remember the dictum salt sugar sex. Okay, salt for the glomerulosa, salt is the mineralocorticoid. Okay, so the zona glomerulosa will secrete the mineralocorticoid, that is the aldosterone. The fasciculata, okay, it is going to secrete the sugar, that is the glucocorticoid, like cortisol, corticosterone, or cortisone. Okay, the reticularis is going to secrete the sex hormones, that is the androgens. Okay, and the adrenal medulla will secrete your sympathetic ANS, okay, the stress hormones, that is the epinephrine and the norepinephrine, or adrenaline or the noradrenaline. Okay, so if they have given the arrow on the medulla, adrenal medulla, then it will be your adrenaline and noradrenaline. Agar reticularis, then androgens. Agar fasciculata, then glucocorticoid, that is cortisol. और glomerulosa में अगर arrow रहा, that is aldosterone. ठीक है. So as you can see here, they have given the arrow on the lowermost part, that is in the adrenal medulla. Okay, they have marked the adrenal medulla. So the answer will be obviously adrenaline and noradrenaline. So the answer here is adrenaline. Okay. So it's very easy, this adrenal gland का जो आया है, very easy. So here also you can see this area will be the capsule. Okay, this will be the capsule. This area will be the capsule. Then you have the zona glomerulosa. Okay, the zona glomerulosa. Then you have the zona fasciculata. Okay, उसके बाद आएगा zona reticularis. Okay, and where you will get entire blood vessels, no, बहुत सारा blood vessels मिलेगा, that is the medulla. Okay, so this is the cortex and this is the medulla. This is the medulla, this is the cortex, बाहर है capsule. ठीक है, so that is how you can differentiate the different areas and the hormones secreted by different areas. Okay, now which of the following is a primary lymphoid organ? तो मैंने already answer mark करके रखा है. So primary lymphoid organ, they have given liver, spleen, thymus and lymph nodes. So out of this the answer is your thymus. So it's very basic question from the histology. Okay, the lymphoid organ. So you know that the primary lymphoid organ is thymus and the bone marrow. Okay, and the secondary lymphoid organ, you will get the spleen, the lymph nodes and the tonsil, adenoids, bronchus, mesenteric and the Peyer's patch. All these are the primary and the secondary lymphoid organs. So उसमें से answer है thymus. ठीक है. Now a question which is mostly, you can say partly it is anatomy, partly it is physiology. So the question came like the primary action of inhibin. Okay, so the primary action of inhibin, so they have mentioned the option: stimulation of secretion of FHS, inhibition of prolactin, inhibition of FSH, and reduces hypothalamic LH releasing hormone. So before that, let us see that. So you know that this is the hypothalamus. Okay, so you have the gonadotrophin releasing hormone, okay, which gives a positive feedback on the pituitary. Okay, okay. Now it will release your FSH and luteinizing hormone. Okay, now FSH will act on the Sertoli cell, and then from the Sertoli cell they are going to release your inhibin, which in turn will have a negative feedback on the hypothalamus, also on the pituitary. Okay, the inhibin will have a negative feedback on the hypothalamus and the pituitary, means it is going to have a negative feedback on the follicle stimulating hormone. From the luteinizing hormone, from the Leydig cell, they are going to release a testis, and it will have a virilizing effect. The Sertoli cell, it will have a spermatogenesis, and this will have again the testosterone will have a negative feedback on the anterior pituitary. It is also going to have a negative feedback on the hypothalamus. So inhibin is having a negative feedback on the follicle stimulating hormone. Okay, inhibin is having a negative feedback on the follicle stimulating hormone. So the answer here is inhibition of follicle stimulating hormone secretion. This is the correct answer. And if the question came on this type, that the function of inhibin is negative feedback, positive feedback, negative feedback to estradiol, positive feedback to estradiol, the correct answer will be the negative feedback to FHS. Either way, inhibition of FHS secretion or negative feedback of FSH. Both the way, the answer will be that only. ठीक है. Okay, now another question came on the epithelial lining of trachea. So they have mentioned about the simple columnar, ciliated, non-ciliated and pseudostratified ciliated columnar. So the you know that the trachea ka epithelial lining is pseudostratified ciliated columnar epithelium. So here you can see that you have cilia, okay, and the nuclei are present in different level, which gives an illusion that it has different strata, but they have only one strata. All the nuclei are lying in the basement membrane, but since they are present in different level, it looks like they are having different, they have stratification, so that's why the name is known as pseudo stratified. So this is the basement membrane, and then you can also see the goblet cells here. So these are the goblet cells, okay, and the cells are columnar. As you can see, the nuclei are near to the base and long, okay, and there is enough cytoplasm in the upper part, okay. The cytoplasm is enough in the upper part. The nuclei are elongated and it is near to the base. So it is a columnar epithelium. So you have goblet cell, you have cilia, and since it is not actually, it doesn't have strata, but it looks like it has strata because of the different shapes and different levels of the nuclei. This is pseudo stratified ciliated columnar epithelium. Here also you can see that in this, it is a pseudo stratified ciliated columnar epithelium, okay. So if you see all the structures, so you can see that you will have cilia here, you will have the goblet cells, okay, and this area is the mucosa, that is pseudo stratified epithelium. Then you have the basement membrane, okay, then you will have the lamina propria, okay, this is the lamina propria. Then you will also have the ducts of the tracheal gland, okay, and then you will have the perichondrium, and uske baad you will have the hyaline cartilage and the chondrocytes, okay. So these are the different labeling of the slide of your trachea, okay. So if you take a cut section of the trachea, okay, then you can also observe a C-shaped cartilaginous ring, okay. The C-shaped cartilaginous ring is present anteriorly. The C-shaped cartilaginous ring made of hyaline cartilage is present anteriorly, and posteriorly you are going to have a muscle that is known as a trachealis muscle, okay. So here you can see that this muscle here, this region is the trachealis muscle posteriorly, and anteriorly you are going to have the C-shape, hyaline cartilage, okay. We'll have the C-shape hyaline cartilage anteriorly, and posteriorly you will have the trachealis muscle, okay. Similarly, this is the lumen, you can see here, okay, the mucosal folds, the lymph node, lamina and all. In the lumen, we have just taken a lumen and studied it. So you can see the pseudo stratified ciliated columnar epithelium on the mucosa, okay. Same thing, you can, this is a division, how you divide. You have the mucosa, you have the submucosa, the cartilaginous layer and the adventitia, and here you can see different nucleuses are at different level, but all the nucleuses are elongated, so it is columnar, okay. And the cytoplasm also is more in the upper part, okay. And then you can see cilia also and certain goblet cells also. So this is your pseudo stratified columnar epithelium, okay. Here you can see the cartilaginous ring and trachealis muscle, which is present posteriorly, okay. You will have a C-shaped cartilage anteriorly and trachealis will be present posteriorly, okay. Okay. Now a question came, a typical question, that is epiphyseal-diaphyseal joint, okay, is a joint present between epiphysis and diaphysis is what type? So they have mentioned synchondrosis, symphysis, synostosis and syndesmosis. So they have mostly mentioned about, so you know that this area is your diaphysis, okay, and this area is your epiphysis, and then you have the metaphysis. So this joint, we are saying about the epiphysis, the joint, that is a metaphyseal plate. The epiphysis and the diaphysis. is what type of joint? So they are asking about this. So the answer here is your synchondrosis. Okay, it is your synchondrosis, not synostosis. Synostosis is not a joint. So the answer is synchondrosis. Okay. Okay, now I don't know about what type of question it came, but there was a image where you can see spina bifida mostly. So you know that there are different types. If there is tuft of hair, then it is your spina bifida occulta. Spina bifida occulta. Okay, if you have spinal fluid, then it is meningocele. If you have spinal nerve, then it is meningomyelocele. These are the different type of spina bifida. Okay, and another one is your rachis. Okay, so most probably the question came on spina bifida, so I'm marking it. I don't know what are the other options. I just got to know that the question came on neural tube defect. Okay, and most probably the answer was spina bifida, and they had given an image like this. Okay, if you can remember, you can write in the chat box what was the exact question on this spina bifida. Okay, so another question is, which type of joint is the first carpometacarpal joint? First carpometacarpal joint is normally very important for like the first MBBS. Okay, it's short notes used to come, and every time in Viva they are asked about the type of joint in the first carpometacarpal. So the type is your saddle. Okay, answer is your saddle. Now why it is saddle? You have to know that. Why the first carpometacarpal joint is a saddle variety of joint. So anybody in the chat wants to answer this? Why do we say it is a saddle variety of joint? So you know that the bone which is involved here, okay. So this is the trapezium, okay. So you have the trapezium bone, okay, and this is the first metacarpal, and this is the base of the first metacarpal, okay, and the first carpometacarpal joint is this one. The first carpometacarpal joint is this one. Okay, now what is the shape of this joint actually? As you can see here, the surface, the articular surface has both concave and convex area. Similarly, in the first metacarpal, in the base also you have concave and convex area. Okay, so both concave and convex in दोनों side में है. So in trapezium, concave in the front to back direction and convex in side to side direction. The first metacarpal is in the opposite shape. So दोनों concave और convex surfaces है, which looks like a, as you can see, it is concave or convex. The first, it looks like a saddle. You know, not the saddle, horse. When you do a horse riding, you have seen the saddle where the person sit, and that is concave or convex. Okay, so because the area is your concave or convex, it is known as your saddle variety. Okay, here also you can see the articular surface, if it is the base of the first metacarpal, and this is a trapezium. As you can see, it is the concave or convex, है ना? It is concave or convex. Okay, that's why it is your saddle variety of joint. Okay, that's why it is your saddle variety of joint. So if they ask you about the first carpometacarpal joint, it is your saddle variety. Okay, the answer will be saddle, concave or convex. Okay, so with this I end. I'm going to end today's session. But out of all the repeated questions, as I have discussed, neural tube defect we will be discussing in the neuroanatomy part 2, and it's very important. If they have given this time, they will also give in the December session. Okay, if it is on spina bifida, then next time you might get a question on rachis, meningocele or meningomyelocele. Okay, so you should know what are the types of neural tube defect. Very important for the exam. Every time it is repeated. Okay, so neural tube defect important है for the December session. Joints, you might get any question. You might get on a synovial joint, you might get on long bones, any question you might get on joints. From the histology part, very common are the glands. So as they have given the adrenal gland, next time they might give the pituitary gland. Okay, the pituitary is also as important as the adrenal. So next time they might give a question on the adrenal or the pituitary. Okay. So epithelium, you will definitely get a question. So you have to know what are the different types of epithelium found in the body. If you remember the whole chart, then it will be easy for you. Okay. Mostly the respiratory epithelium we have not discussed here, but when we are going to study about thorax, anatomy of the thorax, we are also going to study about the histology of the thorax, and that time I am going to tell you about the entire respiratory tree, the tracheobronchial tree and the epithelium involved in those tree. Okay, so that time systematically we are again going to study about the epithelium. So in histology the epithelium is important. Some questions might come on the physiology, the negative and the positive feedback. Okay. Lymphoid organ, as you know, the primary and the secondary lymphoid organ, it is very easy question, very direct question which came this time. And then as I told you, adrenal gland, they have mentioned about medulla. Next time they might mention about the zona glomerulosa or zona fasciculata or zona reticularis. So you know that from glomerulosa you have the mineralocorticoid, that is aldosterone. From fasciculata you have the glucocorticoid, and from the medulla you have the adrenaline and the noradrenaline. Okay. So this is how the slide looks. I think before exam you should also go over the histological slides so that you can identify the slide first. Okay. So they gave a question on parafollicular cells. Next time they might give a question on the follicular cells as well. Okay, so you might get a question on follicular cells also. So you have to identify the slide first, and then you have to identify the cells, and then what are its secretions. So parafollicular cells mostly secrete calcitonin. Okay. Also, this time they asked about the pterygopalatine ganglion. They have marked the location and they have asked. So next time you might get a question on either ciliary or otic or submandibular, or again they might repeat the pterygopalatine as well. So the parasympathetic ganglion as a whole is important for your exam. You have to study this, the parasympathetic ganglion as a whole. Okay. You might get any question on the radiology. On the basis of that you have to answer the questions. Then esophageal constriction, very important, as we have already studied that. You have to study, since this time they have given the distance from the central incisor, so also try to remember in inches. At this time they have asked in centimeters, so next time they might ask you in inches also. Okay, and a vertebral level. So aortic arch they have given 25 centimeter. Next time they might ask the vertebral level, which is at the level of P4. So after that, any scan on the brain might come. You know, you might get internal capsule as asked this time, or you might get caudate nuclei or putamen or globus pallidus. So any question will be asked in this part of the neuroanat, which I have already taught you, and it's getting repeated every year. Okay, every alternate year they used to give either a question on internal capsule or the caudate nucleus. So you have to revise that also in the neuroanatomy. Then fall on the outstretched hand, as I have already told you, scaphoid fracture, very common. How to identify the carpal bones, what is the mnemonic? So you know that if she looks too pretty, try to catch her. After identifying, you have to look after the fracture. Posterior tibial artery, a very important question asked every year, so this cannot be missed. So if they have asked about the posterior tibial artery question directly, next time they will ask it the other way. So you have to know it is palpated behind the medial malleolus in front of the medial border of tendocalcaneus, and you have to ask the patient to invert his foot. So this was the posterior tibial artery. And also I have already told you about the epidural and the subdural. So this is your subdural hemorrhage. So you know above the dura it is epi, below the dura it is sub. Epidural is biconvex and subdural is tricentric or lunar shape. Okay, and epidural or extradural is mainly because of the middle meningeal artery damage, and subdural is because of the bridging veins damage due to subdural which involves the scleral venous sinuses. So it is due to veins. Cleft lip, cleft palate is Patau syndrome, trisomy 13. Trisomy 8 is known as Varkani syndrome. Trisomy 21, Down simian crest, very typical feature. Trisomy 13, cleft lip, cleft palate and extra fingers or toes, Patau syndrome. Trisomy 18 is Edwards syndrome. Okay. So this time the question came on trisomy 18, I hope. Then the nerve which is related closely associated with the patent ductus arteriosus is left recurrent laryngeal nerve. Next time they might ask you on the ligamentum arteriosum. So same will be the answer, that is left recurrent laryngeal nerve. Okay, so this is the recurrent laryngeal nerve. Then they ask you about the corneate segment, very, very important about the corneate segment. So this is the way you have to remember, and the middle hepatic vein divides the whole liver into the right and the left hemiliver. So this time the question came on segment 8. Okay, so this was the segment 8. Then about the question on the testing of abducens nerve, you know the dictum, that is SO4, LR6 and other is 3. So lateral rectus is 6 and it is mostly for the abduction. So for you to abduction, we'll ask the person to look laterally, so to see the function of your lateral rectus. Okay, so the answer is lateral. So this will be the answer, lateral. Okay. Next, the question came on the closure of anterior fontanelle. So I told you the anterior fontanelle will close at 1.5 year. The posterior fontanelle will close at 1.5 month. Okay, 1.5 month. 1.5 to 2 months. The posterior and anterior is 1.5 year. That is 18 months. So the question came on closure, and that is your 13 to 24. That is the range, or 18 to 24. Then leg ophthalmos, mostly due to the 7th cranial nerve damage. Aortic arch, 6 aortic arch, they have arcs on the left side. So always try to remember Delhi, DL, that is ductus arteriosus, is on the left side, and pulmonary artery, PR, that is on the right side. So the answer will be your ductus arteriosus as it came on the left side. Obviously the Trendelenburg sign, you can't miss that. If it is bilateral, you will have waddling gait. If it is unilateral, you will get lurching gait. And we see mostly the abduction of the hip joint. The sagging will be in the opposite side. Gluteus medius and minimus is involved, and nerve supply is your superior gluteal nerve, and it is used to see the abduction of the hip. Okay, abduction or abduction. Answer will be abduction. Okay, the question came on the linorenal ligament at the T12 segment, so you have to also know about the cross section of the body. Okay, so that is how spleen and kidney, the ligament joining that is the linorenal ligament. Okay, this was the question asked. Okay, trapezius palsy, because there is an injury in the posterior triangle, the spinal nerve is gone, trapezius atrophy will be there, the person will be not able to elevate the hand, and there will be ipsilateral, same side, loss of shrugging, that is there will be atrophy on the same side. So you can see that shoulder drop on the same side, or the shrugging will be lost on the same side. So that is the answer, is your accessory spinal nerve. And this I want to rectify. If somebody has the other option, that indirect inguinal hernia, the nerve involved, I have written ilioinguinal nerve. If they have not given inguinal nerve, you can mention the other option what was given. Okay. And then question came on hypothenar atrophy, and this is the cutaneous nerve involvement. So you know that the hypothenar muscle is supplied by your ulnar, the thenar muscle is supplied by the median, on the back side it is supplied by the radius, on the medial lateral lateral 2.5 fingers, and the medial 1.5 fingers is again supplied by the ulnar nerve. So the answer here will be the hypothenar is supplied by the ulnar nerve. So the answer is your ulnar nerve. Okay. With this, I end today's session. I hope you understood well. And see, I have already told you that many questions used to get repeated. So you should try to study the entire topic, so that even if the question came in other way, you are able to attempt. Like the Trendelenburg sign, they have given this time the abduction of the hip joint. Okay, in the Trendelenburg sign, they have not directly asked about the muscle or the nerve supply. So whenever a question comes on repeat, you should study the entire topic. And with this, I end today's topic, and next session will be on neuroanatomy part 2. I hope you attended session, because I'm going to discuss about the CT scans and about the specimens of the brain in the next neuroanat session. Okay. So with this, I end today's topic. Thank you very much. And any doubt you can ask in the chat. Okay. Thank you.